Okay. So today I kind of am hoping to paint a broad picture of the opportunities that we have to change technology and also change perspectives of our referring physicians. One of my least favorite statements that I've ever heard is this one. And I think it was a reviewer of an early R01 grant that I had submitted. Um, uh, and the comment was, why the grant was to, reduce the number of PET CTs, and one of the justifications for this was to reduce radiation to cancer patients. And today, I hope you'll find some good information about why patients who have cancer do not necessarily need to have or deserve to have more and more radiation from medical imaging. And I hope you'll come away from this talk with an understanding of why this statement is not applicable to modern PET CT, why radiation matters, and that there's tremendous worldwide opportunities to improve our understanding and practices around radiation provided by PET CT.
Apologies, sorry for interrupting. Are you sharing your slides? I'm just wanted to double check. We don't see your slides.
You don't. Okay, I thought I was. 1 second. Sorry, I had a bit of a glitch here. Seems to be the theme. Okay, can you see that?
Yep. Thank you.
Okay,
Yes.
sorry, my bad. So this was the statement I was referring to. So why does it matter? These patients already have cancer. So hopefully we'll get away from that today. But it's not only reviewers of NIH grants. This is another quote I heard from a husband getting a little frustrated with his spouse in the department, trying to reassure her that she would be okay having a PET CT performed. And indeed, in a review of radiation safety related to PET, the anticipated outcome of the effective dose really, uh, uh, was lower than the effective dose was lower than many of the other types of studies we do in radiology, and the statement at the conclusion of this study was that maximum uh, annual additional risk because of a single PET CT scan averaged over the general population for incidence of any solid tumors except thyroid cancer or uh, melanoma skin cancer was uh, less than 200ths of a percent. And when evaluated this way, it seems like the risk of PET CT appears exceedingly small. However, a single scan in a single patient across a broad population doesn't actually describe clinical reality. So let me take you through where I'm coming from on this. My initial interest in this area was the result of a study that we originally focused on um, the economic cost of care and differences or lack of differences in outcomes based on level of intensity of post-treatment surveillance in patients with early stage breast cancer. There we go. So in that study, we found that on average, previously treated patients were getting about 1/2 to 1 CT or PET CT or non-breast MR each year after they were treated, with the number depending on age, as you can see in the upper graph here, and complexity of initial treatment, the bottom graph. However, there was a wide range of utilization that ultimately showed significant dependence on the geographic location of patients, like where these patients lived, which hospitals they went to. And even more startling was the ranges of annualized imaging frequency that many of these patients had, up to 9 tomographic imaging tests each year. So when we first looked at this data, we thought maybe there was some sort of error in our data. And maybe we just double counted scans or something like that, until we looked at numbers of scans in similar populations in our own institution and found examples of real patients getting such intensive surveillance imaging. And just over the past year, I've noticed that the frequency in imaging, now not of surveillance patients, but imaging of patients with metastatic breast cancer per se, um, has gone from, once every 6 months, maybe 5 years ago, to once every um, uh, 4 months, once every 3 months. And just over the past 6 months, I've now seen many referring physicians use PET-CT in their patients once every 2 months. And I'll talk a little bit about why that might be troublesome in just a few minutes. So for a patient who may achieve, that was metastatic cancer, but here I'm talking in this study about patients with early stage cancers that they are essentially definitively treated and should be cured, and yet these patients continue to get PET-CT for surveillance. Um, so there's a real decision as to whether this amount of imaging, this amount of radiation is justified in patients who could have essentially been cured. And patients are receiving more and more radiation from medical imaging every day. So um, uh, it's as much as 50% of our background radiation here in the United States is from imaging. A recent study from Harvard looking at PET-CT utilization in all cancer patients found a high variability in the frequency of PET-CT imaging studies ordered by any single oncologist across all cancers, and the high variability in the resulting amount of radiation that the patient received. So in that study, there were over 10,000 FDG PET scans. They found kind of a similar average that we did in our patients, about 1.6 exams per patient over 2 years of study. And so the maximum number of FDG PET scans that any patient underwent in any single year in that study was 7. So not quite one every couple months. But over 21% of these patients had over 2 FDG PET scans in any single year. And 40% of these patients were below 60 years old. Now, in comparing this to institutions where I practiced, I'm really not surprised. As I mentioned, many of our patients get many of our metastatic disease patients get PET scans now as frequently as once every couple of months. And uh, although patients may even have metastatic disease, certain cancer types, particularly breast cancer, are now treated more like chronic disease, with patients routinely exceeding 1 to 2 decades of life after their diagnosis of metastatic disease. And so now it's not uncommon for me to look back in patients' charts as I'm preparing for tumor board and see that they've had as many as 30 or 40 PET-CTs in their lifetime. So we also have some applications for PET-CT that are performed in patients without any history of cancer. We do PET-CTs for neurological diseases such as uh, epilepsy, dementia. We look for cardiac sarcoid. We do myocardial perfusion imaging with PET-CT now. And one of the most kind of explosive growth that we've seen now in PET-CT, and we're just on the very beginning of this, and I think we'll see probably double the number of PET-CTs in the next couple of years due to PET-CT for infection and inflammation. So these are patients without any history of cancer receiving the doses that we provide with PET-CT. So patients don't really necessarily know what they're getting here in terms of the radiation dose, and we as a field really aren't good at communicating radiation dose or radiation exposure to our patients. So a study at Royal Marsden in London used questionnaires to see how aware patients were of the amount of radiation they were getting. with nuclear scans such as bone scan and PET-CT. And a study found that about 1 in 3 patients knew what nuclear medicine even was, um, although that's probably better than our medical students. And then 1 in 5 actually knew what ionizing radiation was. Uh, Only 1 in 5 were actually able to accurately compare relative doses of radiation provided by bone scan and PET-CT with common comparators. And this is what we often do in nuclear medicine is, oh, well, this scan is like, it gives you about the same amount of doses flying from San Francisco to New York City 10 times or something like that. And over 2/3 of the patients said that even though there was a pamphlet specifically designed to tell them about the radiation that they were receiving, um, that they couldn't understand that pamphlet, and there was inadequate information for them about the amount of radiation exposure that they were receiving. So we have ever more patients, cancer and non-cancer patients, receiving PET-CTs, sometimes many of them. These patients really don't know or understand the risks of radiation. So how do we solve this? Well, first, we need to know why patients are confused, and I'm convinced that it's because I'm confused. I don't know many health providers that I work with who can really explain a radiation dose from PET-CT. And one of the reasons for this, we'll delve into in a minute. So what we're going to discuss over the next few minutes is what is the radiation dose associated with PET-CT? How do we begin talking with our colleagues and patients about radiation dose from PET-CT? And what are the ways to decrease radiation dose related to PET-CT? So let me preface this discussion with the fact that I am not an expert in radiation dosimetry nor health physics, the epidemiology of radiation-induced cancers. My interest in this is because I'm a clinician who oversees high-volume PET-CT practice, and I wanted to educate myself so that I could educate my patients. So here goes my interpretation of why we as a healthcare profession are confused. So given the origins and people involved in nuclear medicine, the milligray, or previously the rad, or the concept of an absorbed dose, comes most naturally when we talk about radiation exposure. So we talk about the absorbed dose, measure amount of energy deposited in the mass. We can correct or translate that into an equivalent dose by providing a factor relating the biological effect of that. We can also express that as an effective dose that takes into account variation in radiosensitivity of various tissues and organs. So that's nuclear medicine speak. And then I go across the hallway to our CT suite, and this is what everyone else is talking about: CTDI and DLP. And you all have discussed this the past couple of days. And as Dr. Smith-Byman just mentioned, yes, there are ways to go between these two, but unless you're going to run Monte Carlo methods as you cross the hall, it's sometimes very difficult to kind of change your mindset from one to another. And so, for the sake of this discussion, I'm going to put on my nuclear medicine hat and try whenever possible to use the convention of discussing effective dose. We can see great variability in the estimates of radiation dose to tissues coming from both the PET and CT portions of a PET-CT study. And so we see the many different studies have reported on doses of effective doses from both PET and the low dose CT, as well as super ultra low dose CT, and those patients receiving actually full diagnostic CT with their study. And for this lecture or from literature, we're going to kind of refer to low dose CT as those doses that do have voltage adjustment or KVP adjustment, while still achieving acceptable imaging quality. And I'll talk a little bit more about low dose CT. here in a minute or two. But CTs are acquired along all these three genre here, ultra low dose, diagnostic CT, and in a minute I will talk about the ramifications of that. So at the beginning, or when we first solicited for these talks, we also submitted some questions for CME. I don't know if you still have to answer those questions, but if you do, I'm trying to make this so that you can sit back and relax and enjoy. And so wherever you see a big yellow box, that is a big hint that that's going to be important for one of the questions that you've received. So just remember that low-dose CTs by PET CT criteria are those that are produced using less than 120 kVp, but are interpretable and allow anatomic localization and basic measurements, as well as attenuation correction of PET images. All right, so let's delve in further the discussion of the radiation dose. We'll look first at the radiation dose from the PET study, and then look at the radiation dose from CT and how we might be able to adjust to reduce those in both portions of this test. So this is the radiation dose from FDG or whatever radiopharmaceutical you use in PET, and based upon biodistribution, based upon biodistribution and kinetic modeling, standard estimates of radiation dose to a patient can be made on a total body or a per organ basis. Doses to different organs are reported in radiation absorbed per injected dose. So estimates of organ or total body absorbed radiation dose, the energy deposited per gram of tissue, can be readily estimated. Effective dose estimates are reported in millisieverts per megabecquerel to reflect the measure of radiation-specific biological damage in humans. The contribution of effective dose from CT component is a little bit more tricky. The contribution to the dose from CT ranges anywhere from 20% of a PET CT exam to 72%, depending upon the study. So in this study, looking at over 250 nuclear medicine facilities in Japan, they found little variance in the activity provided by the tracer dose. Okay, so this is the FDG dose, but a lot of differences in the dose provided by the CT portion, depending on the facility. Note, again, the dose estimate here is DLP, so it's hard to know kind of how to compare this information other than say it's quite variable from the CT component. At Stanford, we track the doses that we provide to patients from the CT exam. And so this is kind of full disclosure of what we are doing. And we use tube current modulation on our PET CT scanners, something that we'll discuss a bit more later, but you've heard quite a bit, it sounds like, over the past couple of days about this kind of modulation technique. We combine that with iterative reconstruction to lower the image noise, and we produce non-contrast CTs that are not considered diagnostic when compared to a dedicated scan optimized for some specific portion of the body. However, lymph nodes are measurable, masses are measurable, anatomic correlates to FDG foci are found more often than not. And so the vast majority of the CT portions of our studies are associated with what you see here, the range, the kind of DLP ranges of 20 to just under 600. However, whenever referring clinicians believe it is important to get a concurrent diagnostic CT study with or without IV contrast, we offer that ability as well. A radiation health physicist tracks all of this, and just as they would in any CT department. And it's something we take for granted, of course, at large institutions that have all these modalities, but also having practiced at smaller facilities, those resources aren't always necessarily available. And in nuclear medicine departments that are not you know, geographically co-located with radiation or radiology departments, CT is sometimes an afterthought. So typical DLPs, again, provided by the lower dose non-diagnostic CT associated with our PET CTs at Stanford, are in the range of, let's say, 200 to 600. By comparison, here are some published estimates of DLP of diagnostic CT scans of various parts of the body. So if we were to provide dedicated diagnostic CT to each part of the body, we might be able to estimate that by adding up all these estimates. And that, gets into the thousands DLP. And you already saw from Dr. Smith-Byman's data that the practice out there is not necessarily going to reflect adjusting KVP. And so who knows? These could be even larger. So what do we do? What are some strategies to reduce radiation dose to patients receiving PET-CT? Well, I'm thinking about ways to reduce dose radiation absorbed tissue. We have to think about strategies to make up for kind of the loss of information that comes with dose reduction. So for PET, that's actually easier. There's a lot of leverage because even if we don't improve detector technology, like I'll talk about a little bit later, up to a certain point, we can make up for reduced radiation by increasing the time the patient's on the scanner. Because the more time they're on the scanner, the more information we have. And if we improve the sensitivity of detectors or otherwise provide additional information to the image through AI, we can actually also reduce the required radiation dose injected. And again, I'll talk about that a little bit later. For CT, since image quality is directly dependent upon radiation dose, the best we can do is kind of use the least possible amount to get the image that we need to be diagnostic. So there are several strategies employed to minimize doses of radiation absorbed contributed by the PET radiopharmaceuticals. So for instance, in pediatrics, there are dedicated pediatric dosing approaches with non-linear weight-based dosing that can be found to reduce dose, but generate comparable lesion to background signal. And so really anything that increases lesion to background signal reduces the amount of signal that is initially required, and that reduces the dose that's required in PET-CT. So we can have post-injection fluid intake that washes the blood pool and soft tissue activity out, allowing a potential decrease in injected dose, or at least reduced time in circulation. Same goes for emptying the urinary bladder. The highest concentration of radiation accumulates in the urinary bladder with FDG PET. So there's the opportunity there. There's also technology that can be employed in many scanners, such as time of flight technology. So in modern time of flight PET scanners, if we combine the effects of using 3D and 2D reconstruction techniques and increased axial extent and time of flight capabilities, we can reduce the dose that the patient realizes by 50 to 75%. So that's a big chunk of dose. Now, if we look at just time of flight itself, if we can constrict the amount of volume over using time of flight, at which we are estimating what the image looks like, we can reduce the injected dose by up to a third, and in some of the most recent scanners that even constricted to like a tenth of the field of view, up to a seventh of the injected dose. So this in turn decreases background noise by misplaced events and making it possible to even perhaps reduce the dose further. There are also some future potential improvements in timing resolution that can lead to further effective sensitivity gains and possibly kind of order of magnitude gains, like 10 or 20 times. One major vendor now has an AI solution that can take data acquired on um, non-time of flight scanners that use crystals that have such high sensitivity that they can detect a lot less radiation. And so you can acquire images using those crystals, using low dose, and using AI, turn those images into images that look like time of flight images. Really fascinating stuff. It recently got FDA approval, and we are actually utilizing that in our clinics now. Again, here's the golden frame here. So just remember this picture that anytime you give fluid to a patient, you're essentially increasing the lesion to background signal, and by washing out activity or washing out excess radiation emitting from the bladder. Also, time of flight is a very good technique to decrease the amount of radiation dose or radiation that must be administered to the patient. So, what are some other ways we can, that aren't just giving the patient more fluid? Well, a few years ago, the total body PET concept caught on as a potential for reducing dose. And the field of view of PET has traditionally been limited to about 15 centimeters in the axial direction because the ring of components of scintillation crystals, photomultiplier tubes, etc., are just so darn expensive. And so you really just have to, pass the patient through a pretty skinny ring, and then acquire images doing that. So whole body PET increases the geometric coverage to the entire body, and modern computer systems can actually handle that much concurrent data and have that many channels coming in, and then handle all the calculations required to make a 3D reconstruction of PET. That was not the case even 10 years ago. So photons that originate here can be detected by detectors as far away as the other end of the scanner. And so whole body can actually increase sensitivity because you're not throwing away that data. Sorry, my computer decided to just do its own thing. You're not just throwing away that data, and therefore you can increase the sensitivity of the PET scanner by about 40 for total body imaging. Or if you're only looking at the heart or the brain, you can increase it a factor by 4 or 5. So to get an idea of the relative trade-offs, total body PET images can be obtained with, let's say, 6-fold better signal-to-noise ratio. And I've already told you that's about 1/40th of the scan time or 1/40th of the injected dose. So you can essentially either get a scan in less than a minute or reduce the dose by multiple of 40 and image for the time that we typically image now, about 15 or 20 minutes. Now this is, was first popularized by Simon Cherry and Ramsey Badawai up at UC Davis. That a company, United, first started making these whole body scanners. Since then, two major commercial vendors, GE and Siemens, have come out with their own versions of this. Siemens covers about 120 centimeters, so that's from like base of the skull to the mid thighs. GE covers top of the head through the mid thighs. They're not quote unquote whole body scanners, but there are very, very rare instances in which we need data in at least clinical PET, that we need data below the mid thighs. So they do the job for, and you can imagine the difference in price of a scanner that covers from the top of the head through the feet through versus a scanner that only covers 3/4 of that. So there's a lot of excitement there because you can imagine, the reduction. We're not going to, uh, put patients on a conveyor belt and image them for a minute each. By the time you get the patient on and off the scanner, that's already like 5 to 10 minutes. So, if we take a 5 minute image and then utilize the rest of that sensitivity for reduction in dose, that's probably going to how it will fall out, at least in our clinic. Um, so in addition to that, we've also have the revolution of digital PET. So traditional PET scanners have used a number of different um, doped crystal materials as scintillation detectors. Those are like sodium iodide, lutetium yttrium orthosilicate, or LYSO, bismuth orthosilicate, BSO, and then we couple those with multiplier tubes to transmit the detected signal into electric current. Digital PET refers to a system that uses semiconductor materials rather than these crystals, these big crystals and photomultiplier tubes. Um, and to compare kind of the sensitivities of these kinds of scanners, sorry, we use something called the TAP, the time activity product, and it simply is defined here. Then compared to a PMT-based PET system, the photomultiplier tube, PET digital systems provide comparable image quality with up to as much as 70% less time activity products. So, meaning you either can image the patient much less time, or you can inject much lower dose. So this means, of course, increased sensitivity that can be used to decrease the amount of activity that we administer. And finally, various PET denoising algorithms, AI algorithms, have been trained with the idea to decrease time or dose by taking photon poor noisy images and denoising them. And a Geneva group has used a cycle gain and residual neural network models to predict full dose PET images from low dose PET images. For example, the cycle gain network, the cycle gain network is able to synthesize clinically full dose whole body PET CT images from low dose images with 1/8 the standard injected activity. So these images present a similar performance in terms of lesion detectability, quantitative scores, and quantification based on SUV. So in other areas, higher doses required for dynamic imaging studies, such as those performed in like quantitative myocardial PET, computational images to reduce noise by simulating a flow using a percentage of full dose delivered. Those types of methods have been developed as well. And finally, these approaches are really receiving further validation in the literature. So we've looked at the PET component to reduce dose. Now let's look at what we can do to CT. So we have multiple parameters that can be adjusted to reduce the dose from CT, as you've seen. And of course, KBP has been, as Dr. Smith-Hyman has highlighted, is really the key. So reduction in the patient dose will, in some cases, affect image quality for diagnostic evaluation. So when altering a protocol, we must kind of reach a balance between this patient dose and image quality of the CT to meet the diagnostic needs of the patient. So all of these different parameters could be adjusted. And I will just kind of fast forward, because you've talked a lot about all this already. But I'll fast forward to, on a population basis, programs that focus on reduction of radiation dose in PET CT produce really some significant results. So In this survey of facilities across Korea, the use of dose reduction protocols in CT were associated with really significant reductions in total effective dose. Um, Interestingly, it was pointed out in the discussion in this article that those patients where a CT dose reduction protocol was used, as you can see here, it turned out the dose from the FTG was also reduced. And perhaps this is due to specific individuals at those institutions or radiologists who have specific awareness of radiation dose and generally are interested in minimizing radiation dose to patients. So again, it's not something that we can kind of roll out and just assume facilities will abide by, but we do have to have champions at each facility who really care. So this brings up, so what is the purpose of the CT in PET-CT? And how good does that image have to be? So how beautiful does an image need to be to answer a clinical question? A recently published debate between kind of the two major camps here outline the two very different perspectives. And this was the perspective from those who believe that PET-CT should be used to its full diagnostic potential whenever you image a patient. And I'll just quickly read it as we move into an era of personalized medicine. It is crucial that we obtain the most accurate anatomic and functional information possible so that we can make informed treatment decisions for each patient. It's time for us to put the full diagnostic power of CT into PET-CT. So those are the gung-ho folks. And then we've got the other side, that without a net clinical benefit for the patient, performing a costlier study with increased risks ranging from increased radiation dose to possible contrast reactions is not fully justified. As the debate continues over the use of IV contrast material for PET-CT, we must first and foremost keep the patient in mind and acknowledge that more is not always better. And so you can see very different approaches to patient care. And so who's right? And I'm not sure that there is someone who's always right all the time, but this is where I've tried to be educated from the literature. And so what does the literature say about the use of CT component of the PET-CT scan solely for attenuation and anatomical landmarking rather than acquiring a fully diagnostic CT? The Italian experience with lymphoma found that contrast-enhanced diagnostic CT did lead to changes in stage in 3.5% of patients, but it didn't add anything to patients in whom they were evaluating response to therapy. And this has been borne out elsewhere in the literature. So another study of all cancer types in 100 patients, the contrast-enhanced CT versus just a low dose CT produced significant number of discrepancies, about 194, but mostly those were whether or not there was an additional lymph node among tens or hundreds of lymph nodes involved, or an additional visceral metastasis. And these discrepancies would have led to altered management in only 2 patients, so 2% of patients. So our approach at Stanford is a little bit somewhere in between. Vast majority, as I mentioned, of our PET-CTs are ordered for response assessment and surveillance. And and so most of these are performed with CT for anatomic localization only. Diagnostic quality CT scans can be done in conjunction with PET-CT, but we do tend to reserve those for staging or restaging settings, and therefore maybe only 10 to 20% of our PET-CTs are indeed diagnostic CT. All right, we've talked a lot about dose modulation. Dose modulation is the key, and for the most part, CT dose modulation has been shown to have a relatively negligible effect on the reconstructed PET images. For example, using the care package from Siemens in a Phantom study. The institution in Denmark found that it demonstrated insignificant differences in PET activity quantification, and we're talking about up to maybe less than 1% when using the optimal tube voltage advised by the care package. So we're not concerned that dose modulation is going to necessarily affect our SUVs in any specific manner. And as long as we consistently perform studies in a similar manner on every patient, we'll be good. Again, I will just reiterate that dose modulation, particularly using KVP modulation, but either KVP or current is key. And so thus far, I've talked about fully diagnostic CT with kind of IV contrast, the whole bit, for anatomic localization and attenuation correction. I'm sorry, versus CT for attenuation correction and anatomic localization only. That already produces a significant decrease in the amount of total radiation the patient receives. And so now, what is ultra low dose whole body CT? So these studies are required for attenuation correction only. So in order to provide a PET image that can be interpreted, now we have to acquire some sort of data that we can make an attenuation map with, so we can correct for attenuation artifacts in PET CT. So these CT images are not of a quality that can be interpreted and are really very rudimentary. But there's specific instances where this is diagnostically sufficient in order to where the PET portion of the exam is really the key. And particularly in our patients where we follow myeloma or lymphoma patients with multiple monthly or bi-monthly studies over long periods of time. So in a study of patients with proven multiple myeloma who underwent dual tracer PET CT and included both a diagnostic whole body CT and I'm sorry, low dose CT versus a whole body ultra low dose CT for attenuation correction only. Only two of the lowest radiation dose conditions here produced artifacts in CT that degraded the correction of PET images. So for all these other low dose conditions, PET contrast recovery coefficients typically vary less than 1%. And despite the relatively poor image quality of the ultra low dose CT, 95% of the bone lesions were actually identifiable. So other studies have confirmed that reproducible quantitative PET data can be achieved using ultra low dose CT. And now we're talking about less than one or as low as 0.3 of a millisievert dose to the patient, exceedingly small amounts. Just note that AI, seems to be the future everywhere we look. And Young Ho Seo's group at UCSF posed the question of whether AI could help take the CT data used for attenuation and scatter correction from a patient's initial PET CT exam and use it for those functions in future PET CT studies that a patient might undergo, so as to avoid additional CT dose for these functions every time the patient had a PET. And as I've mentioned, some of our patients are frequently getting PET CTs to look for response to therapy. And so this is a perfect application for that. Obviously, not doing not doing the CT portion of a PET CT, and instead doing a PET MR would seem to be the optimal solution. And in a way, it is, but the use of PET MR can decrease dose by about 80% in these patients. But of course, for certain diagnostic tasks, PET-CT is more helpful than PET-MR, and there are only a handful of PET-MRs out in the community, so that doesn't really help address. And we typically have as many, do as many as 60 to 80 PET-CTs a day at Stanford, and uh, putting that kind of throughput, we'd have to have dozens of PET-MRs sitting around. So not really practical, but certainly there's a lot of interest in the literature about PET-MR for this application. So here are the key points that I hope you'll take away from our discussion today. That radiation from PET-CT really does matter. Many patients who are now being treated chronically for cancer receive dozens of PET-CT imaging studies, and so we don't know the ramifications of that yet. And we certainly don't know the ramifications of PET-CT applications in non-cancer patients yet. Although, if I'm sure if some of you were interested in studying that, we have been doing PET-CT for cardiac imaging and neurologic imaging for decades. So that might be something that one could look at. But very soon we'll be doing a lot of whole body PET for inflammation and infection, and this will be very interesting to see how we can implement low dose opportunities there. Practice of PET-CT and technical parameters of CT vary widely, and you already know that. And CT of PET-CT contributes anywhere from a significant portion to the vast majority of radiation dose to tissues in PET-CT. So we have lots of opportunities for improvement and throughout the community, and in particular defining limited indications when full diagnostic CT may provide treatment altering data. So I will end there. My apologies if I rambled on a bit, Dr. Smith.
I did not hear any rambling. I thought that was a fantastic overview of PET-CT that I'm thrilled that that you shared. So thank you for joining us. There were a couple of questions. Well, the first one says, thank you for the presentation. Just a quick curiosity if your slight portion of your accent is mildly Scottish by any chance.
I No, but thank you. It is. I'm not from Scotland, although my great grandfather was. But
So I thought the presentation was super interesting, and I'm wondering how the discussion goes with your referring providers in terms of doing a full diagnostic or not doing a full diagnostic CT. Is that a hard discussion to have with your oncologist? Particularly, if they're the persuasion that the more information's the better, or have you figured a way how to have those conversations in a way that they accept the goal of keeping the doses as low as possible?
so interestingly, I've found the places I've been at that it's really the culture really matters, and if the radiology hasn't pushed it to be the most imaging all the time, then the oncology community is happy to have the data, and they if the radiologists say that it's just as good, and they go with it. So it's really, and I know there. I mean, I of course have been in situations where oncologists push and push to get contrast enhanced CTs on all their patients, um, over time, with a little bit of discussion, they yield, and they understand. I mean, they understand now that we're not talking about a single scan and once every 5 years or just to stage a patient. Now we're talking about multiples. I think, fortunately, insurance companies have helped us here a little bit too, and by not approving uh, both diagnostic CT and PET at the same time. And so now we do have many clinicians who trade off. Once every 2 months, they do one or the other, and they're able to get that paid for.
I think that's a really important insight, that sometimes the decision not to cover a scan reflects the evidence more than the perspective more is always better all the time, which, partly it's a cultural issue, and partly I think is not acknowledging some of the potential harms of what we can do. So there are two more quick questions. How often is follow-up PET-CT in research studies that require this kind of imaging in your practice?
Maybe 10%. I mean, the volumes that we have cannot be explained by research. I mean, and I'm also very much involved in monitoring all of our clinical and translational research in our department, and all the studies. I mean, right now there are probably about 120 studies that, clinical studies across the cancer center that are requiring PETs, but our volumes are not because of that.